Okay, red cells, white cells, and protein in the urine. Very common findings. And what should I do about them? I'm just going to go a bit quickly because I want to meet the timing and no one wants to spend Saturday afternoon looking at urine. So this is a very, very common scenario. Young female, dysuria for 4 days, and you did dipsticks and WBC is positive. So in the absence of markers of complexity, structural, functional abnormalities, stones and obstruction, surgery, instrumentation, obstruction, diabetes, immunosuppression, and pregnancy. So if this lady doesn't have any of these markers of complexity, and if it is not a male, we can manage as for uncomplicated UTI. So for this, the subsequent speakers will be talking about the management of UTI. So we recommend maybe a short course of Bactrim for 3 days, and most of the time it should be able to clear the infection. But we have this other case of let's say a 58-year-old Chinese male with gout, some gastritis, symptomatic, was recently given omeprazole, and he complains he's generally unwell for a week and comes in with a discolored urine. So a dipsticks is done, and this also shows a pyuria. Okay, confirmed on the UFIM, a white blood cell of 45 cells per microliter. So in this case, what are the differentials to consider? For pyuria, I always say that the first differential is UTI and the second differential is UTI as well. So the first differential is, of course, the run-of-the-mill infection where there's a bacteriuria that correlates with its symptoms. The second UTI category, it would be things like a non-gonococcal urethritis, a STD, prostatitis, where the bacteria is actually sequestered within the prostate itself, and fastidious organisms such as TB, all quite rare, usually in more of the immunocompromised patients. And also not forgetting partially treated UTI, as in recent antibiotic use, and such that when you do the urine culture, it's actually negative. Other differentials which would require further evaluation would be things like acute tubular interstitial nephritis, ATIN, and the chronic form, and the cholesterol crystal embolism, but this is usually after a recent cardiac cath. The differentials from number 2 to number 5 will give you a sterile pyuria. For things that are happening high up in the kidney, inflammatory conditions may give you white blood cell casts, and sometimes you have an eosinophilia when you do a full blood count on a patient. Okay. So what's the significance of it? Of course, the first exclusion would still to look for UTI symptoms, but this case being a male, if we suspect a UTI, we will actually have to refer him to the urologist for further evaluation. Sometimes we might want to suspect, let's say if new medications have been started, or the patient comes with any other symptoms, and with a sterile pyuria. So what we have is acute interstitial nephritis, and the most common cause being drugs and toxins. Others would be like vesicular-ureteric reflux, even multiple myeloma, and the immune-mediated conditions such as sarcoidosis and Sjogren's syndrome. So of course this needs a hospital-based evaluation. But one first step to look at would be to see if any of the commonest drugs and toxins have been started recently. So this gentleman, being someone with gout, may have had a recent use of NSAIDs or the COX-2 inhibitors, and he was recently started on omeprazole as well. A lot of other drugs, there's one whole long list, these are the commonest ones. The others would include actually antibiotics such as the penicillin-based ones, sulfur-based medications as well. Okay, so while waiting for the patients to be assessed further, one very useful thing to do for the patient would be to withdraw these medicines or to avoid using them, which would complicate matters some more when we do the evaluation. Okay. Now we go on to red blood cells in the urine, hematuria. 2 case scenarios. The first case scenario, probably something that is encountered quite frequently as well. Someone, 50-year-old lady, no past medical history very well. A pre-employment screen gave us a dipsticks of a RBC 1+. She has no symptoms at all. When you do a UFIM, it does confirm that there is an asymptomatic hematuria. Of note, there's no protein in the urine. In contrast, another case example, a 19-year-old Chinese male serving NS. So complains of gross painless hematuria for 2 days, had URTI a few days ago, and when you examine him, other than a sore throat, there's nothing else, blood pressure is elevated. You ask him for the urine, he gives you this, This one, if you dip the dipsticks, it's just going to give you 3 plus. Okay, so both scenarios may be encountered. Red blood cells in the urine. So what do we need to do? The first step is to actually decide where's the blood coming from. Is it a non-glomerular bleed, that means a urological condition, or is it a glomerular bleed where it is a renal condition? Because this would actually determine if you need to refer and to which discipline that we refer to. Okay, of course, it is much to the benefit of the patient when the first hit, the referral lands in the correct specialty. So what would tell us that it is a non-glomerular bleed? So symptoms such as pain, if the patient comes together with a loin to groin pain, then that would also suggest maybe there's a stone and maybe the hematuria might be related to that as well. Or there's hematuria on different phases of urination. Sometimes the patient might tell you that there's blood when it first pee and then after that it clears up. So this might suggest something that's below the bladder in the urethra. All right, so the phases of urination. So if it's red throughout, then we can't really say that it is a lower tract issue. Usually if there are clots present, it's suggestive of a urological source of bleeding. Or if you want to send for a urine phase contrast, I don't find it very, very accurate, but if you see mainly isomorphic RBCs as contrasted to dysmorphic RBCs, then you might say that this might be a urological bleed. Okay. If it is a glomerular bleed, then we have to actually look out for symptoms that are suggestive of an acute glomerular nephritis. So these 3 things here are what constitutes a nephritic syndrome: hypertension, a cellular urine, and renal impairment. Of course, if you catch early enough, then the renal impairment may not show. One good sign is that it often comes with significant proteinuria if the disease is significant enough. The other complaints that the patient may have will be a smoky urine, cloudy urine, okay? And sometimes if the cast are present, it's not useful if it's absent, but if it is present, a red cell cast would also point towards a glomerular bleed. All right. So for the NS boy, that it looks like someone with hypertension, hematuria, it looks like what we call a synpharyngitic hematuria together with a sore throat. And that's usually suggestive, one of the ways that IgA nephropathy might present. So what do we do for that young NS boy? Basically symptomatic relief. If it will be good to check the creatinine because that will determine the urgency of the referral. Let's say if the creatinine is normal, usually after the URTI resolves, the hematuria will resolve together as well. But he requires a non-urgent consult to the renal physician to make sure that there's no ongoing low-grade glomerular nephritis ongoing. For such patients, usually they're quite well. We will send them actually after initial workup back to the primary health to follow up. So for those follow-up cases, they may have this hematuria on and off again with the URTI. So it's just reassurance, making sure the renal function is not adversely affected, and to just continue monitoring as well. Blood pressure control is always useful. The other case of the cleaner, asymptomatic microscopic hematuria picked up on screening, we have to decide if there's a need for further evaluation. And usually a urological evaluation is indicated. And this is the American Urological Association guidelines. It's a bit strict. It used to be age 50, but now it's age more than 35 years. Any one of these factors: smoking, exposure to chemicals, especially the printers, painters, chemical plant workers, a history of gross hematuria, chronic cystitis, pelvic irradiation, cyclophosphamide, which causes bladder toxicity, indwelling catheters, and analgesic abuse, which of course predisposes the patient to urological malignancies. So this will have to be sent to the urologist. After the urologist has assessed, most of the time, we don't find anything with a cystoscopy, with a CT, IVP. The patients would usually be told to go back to primary care and continue to follow up. So what do we do with these patients? So let's say we will usually advise that you check the urine dipsticks or the urine FEME once a year. And if you find that 2 consecutive annual analysis, there's no red blood cells in the urine, you actually can discontinue the follow-up. All right? If there's persistence, sometimes the patients will just have a low-grade red blood cells in the urine, asymptomatic, it is to continue the annual follow-up. Okay, and the annual follow-up should comprise, besides the urine dipsticks or the urine FEME, a blood pressure check as well. Because sometimes what happens is that it's not a urological condition, and we picked up glomerulonephritis at a very early phase. And later on, they may start presenting with the nephritic picture, with high blood pressure, red cells in the urine, and even proteinuria. So this, on the annual screening, if it's picked up very early and referred appropriately, would be very useful to catch the disease while it's in a very early stage. So these are the renal medicine or glomerular diseases with isolated hematuria. And it will be the IgA nephropathy, actually quite common in our local population, Alport syndrome, a hereditary form of nephritis, which can come together with a positive family history. And also this condition called a thin basement membrane disease, which is quite common, not really a disease in that the patients usually are asymptomatic and there's no long-term issues with the renal function. And this would usually require annual follow-up. All these conditions, after initial workup, would just require annual dipsticks. The RBCs are going to be there, it's going to be persistent, but if there's no proteinuria, if the blood pressure is normal, then there's no cause for worry. So this is another case of what we call a cellular urine, where the white blood cells and red blood cells are positive. In a 34-year Chinese male, hypertension, single medication, BP remains quite high, 161/90. So either on the dipsticks or the UFIM, you see both red cells, white cells positive. So these are warning signs. Although the creatinine is normal, it is suggestive that this patient also has a chronic glomerulonephritis as well. Okay, and this needs further evaluation. Glomerulonephritis can present with variable severity. So those that usually land in the A&E will be very unwell, someone with a rapidly progressive GN. But those in the primary health tends to be this very mild, chronic, indolent cause, very asymptomatic. But nevertheless, you should follow up because the renal disease can over the years progress towards end-stage renal failure, sometimes even silently. The list of common glomerulonephritic conditions, IgA, post-infectious GN, lupus, vasculitis, and membranoproliferative GN. Not important, we do need a renal biopsy for us to determine, because the presentation would be the nephritic picture. Okay, but while we have picked up these cases in the primary health setting, initial management is very important. First, check the serum creatinine, because that will tell us how urgent you need to refer the patient. The other thing is blood pressure control. Because even after it lands in our clinic, if the blood pressure is very high, we cannot safely do the renal biopsy. So sometimes then we have to have a few more sessions to control the blood pressure. So it would be very useful to control using whatever agents. The recommended agent is of course ACE and ARB, but I understand you may not be comfortable using ARB or ACE inhibitors in a setting where the creatinine might be slightly elevated, or if you suspect a renal disease. But any form of blood pressure control, any choice of the blood pressure agents, if you are able to hit the targets, then it makes things much faster for the patient when we can do a renal biopsy very early on and find the underlying condition. And of course, symptom control. If they have a bit of edema, some furosemide might actually help relieve the symptoms and also control the blood pressure as well. Okay. The last part is protein in the urine. So this is another very common example, relatively elderly Chinese male with diabetes, not very good control with retinopathy, hypertension. So we have this urine albumin creatinine ratio. So let's say if first time seeing you in a clinic and you do this as part of the routine screening, which is recommended at least once a year. So 300 milligrams per gram, more than 300. So what does that mean? There's a lot of confusion with this urine albumin creatinine ratio. So let me just go through a few ways that we measure protein in the urine. One is the urine dipsticks, very fast, very quick, but it's semi-quantitative, and it sorts of tells us the concentration, which is in grams per liter. 1 plus, 2 plus, 3 plus, there's a certain range to each plus, but because it's in concentration and we don't know the actual grams per day, which is what we're interested in, we call it semi-quantitative measurement. Gold standard, 24-hour urine total protein. So normal is less than 0.3 grams per day. proteinuria more than 0.3 grams per day, nephrotic range more than 3 grams per day. Gold standard, but our patients do not like it. Ask anyone lug a bottle around for 24 hours. They do not like it, or they do not do it properly. They will miss samples and we don't get an accurate measurement. So we do a spot sample. And one of the useful things is the urine albumin divided by the urine creatinine, which is urine albumin creatinine ratio, converted to similar units in grams, because usually creatinine is measured in micromoles or millimoles. Okay, so a 30 milligram per gram, that's why your lab gives you such a strange unit. Actually, it's a unitless number, it's a ratio. So if it is 30, if you do a 24-hour UTP, it's actually equivalent to 30 milligrams per day, 1 for 1. And if you convert to grams per day, it's 0.03, while 300 actually means 0.3 grams per day. So this range, 30 to 300, is traditionally called microalbuminuria. That means it is less than 0.3. If you do a 24-hour urine total protein, you actually not see it, and they call it microscopic levels of albuminuria. So it's a misnomer. The albumin is still the same size. Right? Now the terminology has changed a little bit. Not important, but basically normal albuminuria is now called albuminuria stage A1. Microalbuminuria is now called stage A2, so within 30 to 300. And to make things worse, they have unfriendly labs that gives you this type of units. But so be careful of the units that you see it, because it's between 3 to 30. All right? For milligrams per millimole. Okay? The other way we measure is urine protein to creatinine ratio, and this is also 1:1. All right? 1 gram per gram means 1 gram per day. And the ranges are the same. It is convenient for the patient. Usually we use this for higher levels of proteinuria. Okay? So for that case, the diagnosis of diabetic nephropathy should be one of exclusion. Exclusion in the sense that the patient doesn't present with any other issues, like if they have joint pain, they have rashes, they started some new medicine. So we want to sort that out before we label it as diabetic nephropathy. Okay. Besides exclusion, is also a risk assessment. So it's likely we don't biopsy we biopsy most of the GNs, but for diabetic nephropathy, if we see that this patient has a long duration of DM, suboptimal control, microvascular complications, and there is proteinuria, and more importantly, observed progression from normal albuminuria to microalbuminuria to overt proteinuria. So if you have been following up and you see this progression, and you say, it's likely due to a diabetic nephropathy. All right. So this is the last case. It's actually a real case from a GP. Very excellent control and very good monitoring of the microalbuminuria. And this patient developed mild leg edema, and he did a 24-hour UTP. And this GP actually recognized that there's something wrong. Diabetic nephropathy doesn't jump from normal albuminuria with ARB on board all the way to a nephrotic range proteinuria. So it referred over. Okay. So this patient actually has got a nephrotic syndrome. And the nephrotic syndrome, you need to meet 3 out of 3 of the criteria. Proteinuria more than 3 grams per day. Hypoalbuminemia less than 30 milligrams per deciliter, plus the presence of edema. All right. So sometimes the patients are referred over to say maybe this is nephrotic syndrome. It would be useful to have all these 3 criteria. And a lot of times it's actually the patient might have edema, but the proteinuria actually didn't cross 3 grams. So might have been more useful to maybe consider IHD or congestive cardiac failure as the first point of investigation first. All right. And these are our usual common causes. Diabetes is very, very common, 50% of the time. Glomerular proteinuria, which might be minimal change disease, membranous FSGS, and sometimes myeloma. All right. But definitely needs further evaluation if the patient hits all 3 criteria, and we call that nephrotic syndrome. All right. Okay, so this is what we have gone through: white cells, red cells, and also proteinuria. A lot of times there are a lot of low-grade presentations, so most of the time we'll need to engage and ask the primary health doctors to continue to follow up. And most of the time it's just to understand that the process like the hematuria is going to be persistent. And usually if there's no proteinuria, proteinuria is always a sign that we worry about there's ongoing renal damage, irregardless of the underlying cause, be it lupus, be it diabetes. When there's proteinuria, we get worried. But usually if there's no proteinuria, then we are quite reassured that there's no active or very aggressive underlying cause. Okay?